Okay, we are going to open this session on NAFLD and NASH. So there will be two parts, one part on NAFLD NASH session and the second part with cross-path liver metabolism with interactive discussion. So I'm sharing this session with Professor Haroun Sanyal. I think you all know these good guys.
Thank you.
Very famous. And so we start now with the first presentation by Pierre Bedossa. And you have 10 minutes to tell us how, when you are a pathologist, you characterize NASH. Thank you, Pierre.
Can I have the first slide, please? Okay. Okay. So thank you, Laurence and Haroun. It's my pleasure to be here. So I will explain you that if you want to make a diagnosis of NASH, you need a biopsy. And of course, the reason is that the definition of the NASH is based on histological features and on association of histological pattern. And to the best of my knowledge, NAFLD and NASH is the only chronic liver disease whose definition is based solely on histology. We don't have viral serology, we don't have autoantibodies, we don't have genetic biomarkers. So based on the definition, the diagnostic of NASH rely on histology. And if you go back to this recent paper produced by FDA regarding the guidance for development of treatment in NASH, it's clearly said that NAFLD include a spectrum of histological changes going from fatty liver to chronic inflammation, NASH, and currently there are no clear criteria to identify this group of patients. So unfortunately, if a diagnosis of NASH is required, then the liver biopsy is mandatory. Of course, I know that maybe Laurent in the next talk will argue against liver biopsy and will say that it's not a reliable procedure. Let me say just first that the sampling issue is not really an issue. If you get a 20 millimeter long biopsy done with a 16 gauge needle, this will provide enough material for a robust diagnosis of NASH, because NASH is different from other chronic liver disease. If you look to this whole liver section, you will see that steatosis, for example, is located not randomly. It's located in very specific areas. And if you look at higher magnification, what you will see is this is the central vein, the zone 3, central vein zone 3, portal tract. And which is very different from other chronic liver disease is that each of the central areas, the zone 3, shows a lesion. And if you consider that the distance between the portal tract and central vein is around 1 millimeter, you can imagine that if you have a 20 millimeter long biopsy, then you will at least 10 areas where you can see the lesion. So biopsy sampling and error related to sampling is probably not a relevant limitation of the biopsy. Observer variation, oh, okay, thank you. Observer variation is also not an issue if the biopsies are reviewed by experienced liver pathologists using well-defined histological criteria. And both in NASH or the FLIP papers, there are studies of inter- and intra-observer variation who show that, for example, assessing of fibrosis or steatosis is very reliable. Of course, it needs training and experience as everywhere in medicine. Training and experience not only from liver pathologists, but also for the hepatologists who will perform the biopsy. And this biopsy should be done by someone who is experienced in the way to perform liver biopsy in the best condition. It needs also training and experience from the pathology lab that will prepare the section, and of course, for the pathologist. So there is a chain that has to be followed in order to get a good material to have a diagnosis. What about the characterization and the histological criteria of NASH? I just got here some most important paper about the definition of NASH. It's interesting to go back to the early paper, which was from Jürgen Ludwig, who was a pathologist of the Mayo Clinic, and he was the first to describe NASH as an acute alcoholic hepatitis-like lesion with steatosis, Mallory line, and polymorphonuclear. And from this definition, it has drifted to a group of lesions which are less severe than the ones that have been described by Jürgen Ludwig, and it is considered now that NASH is for diagnosis of NASH, you just need a little bit of steatosis, little bit of inflammation, and hepatocellular ballooning. It's a little bit a pity because there is a shift from what was a rare and severe disease with obviously a bad prognosis to a wide histological spectrum, including mainly minor histological disease. And I will show you in a moment. But that is what we like as a NASH. This is a typical lesion. When you see here the central vein, you see the sinusoidal fibrosis. You will see also at higher magnification the ballooning of hepatocytes, Mallory-Denk bodies, inflammation, and also very often some fibrosis. So this is what is a NASH. Oh. Can I get, well, okay. So you recognize the lesion. And as I mentioned, there is a wide spectrum of disease. So in order to weight the severity of the disease, the NASHian define what is a NAFLD activity score, or NAS, adding the steatosis, inflammation, and ballooning. But unfortunately, ballooning, which is the most relevant disease, is underweighted compared to steatosis and inflammation. So if you compare, for example, these two features, one is a typical NASH here, and the other, which is also a NASH, because you have steatosis, inflammation, ballooning. Both of them have the same NAS, 5, but one is mainly related to ballooning and inflammation, and the other one is only related to steatosis. So it's probably time to shift from this dichotomized approach, steatosis versus steatohepatitis, to a more integrative classification that assess steatosis, activity, and fibrosis. And of course, this is a major issue because fibrosis is a main lesion. This is a prognostic feature, and you have here the staging which have been defined by the NASH range that make a difference between the mild or moderate lesion, stage 1 and 2, to the advanced fibrosis, stage 3 and 4. And of course, as you know, fibrosis staging is the only predictive prognostic marker either regarding liver-related mortality or overall survival. So with this approach, using activity from one side and fibrosis from the other side, then you can classify all the biopsy within this score with, for example, this type of lesion with very few, little fibrosis, no ballooning, no activity here. And this one in the opposite, which is advanced, which is cirrhosis, with ballooning and a lot of activity. So this approach allows you to classify all the biopsies. So as time is short, I will go to my take-home message. NASH is defined by histology, and if a certain and a sure diagnosis is needed, for example, for clinical trials right now, then the liver biopsy is mandatory. It is a robust procedure. Of course, it's unpleasant, it's invasive, but it is a robust procedure that can assess at once all components of the NAFLD if it is performed by trained physician, and I mean both hepatologists or radiologists and pathologists. An analytical description that reports activity and fibrosis in a semi-linear fashion is more appropriate than this dichotomous classification, NASH versus no-NASH. But of course, a liver biopsy is not a screening tool, and biomarkers are strongly needed to select patients at high risk of severe disease, and who will need, however, a biopsy. But there is a problem. And the problem is the following. This is a problem of accuracy. Based on the definition of the disease, you need the whole liver to have the perfect standard diagnosis. You will get the sharp image, you will get the ballooning, you will get everything you need. liver biopsy is only part of the liver, so this is an estimator of the perfect standard, what we call the gold standard. So the image is a little bit fuzzy. And since this is a gold standard from which you can define and devise non-invasive biomarker, then you lose the accuracy. And you have here an estimator of the estimator, and the picture becomes misty. And I just want to illustrate that with that. This is a whole liver, the sharp image. This is a liver biopsy. So you still recognize the guy, but you know it's not so sharp that it is. And this is a biomarker. So I think it's clear, and I will let now Laurent Castera to predict histology with biomarker. Thank you.
So we move on to Professor Castera to provide the counterpoint.
So thank you, Pierre, for the kind introductions. Thank you, Patrick, and the organizer for the kind invitation. As been mentioned, fibrosis stage, but not NASH, predicts mortality. This has already been shown. If you're F3, F4 with advanced fibrosis, you're more at risk of complication and dying. And actually, the risk of severe liver disease range from 1.9 in F0 patients to almost 100 in F4. The risk, the liver-related mortality, no surprise, is of course much higher if you have advanced fibrosis, and the risk is above 40. But interestingly, also all-cause mortality, including cardiovascular mortality, is increased by 6 in F3, F4 patients. Finally, as a clinician, the challenge is to identify patients with NASH and advanced fibrosis, because not all of them will progress. So, liver biopsy, an unrealistic and risky procedure given the burden of the epidemic, would be like, let's say, building a wall between the US and Mexico. A lot of data have been published in 2018. This is a study showing the distribution of NASH by fibrosis stage. And you can see that the estimated prevalence in France is around 300,000 in 2016, but expected to increase to 800,000. These are just predictions in 2030. But it gives you an idea of the burden. So diagnosis NASH with advanced fibrosis with liver biopsy, as I mentioned, is an unrealistic procedure. Look at the number of hepatologists in France. Look at the number of patients, as I already mentioned, more than 3,000. Look at the number of pathologists. It's even smaller. And also, of course, you need the good pathologists. No, non-invasive tests are ready for prime time. The question is, what are the best tools? So let me introduce the amazing peniscope. Okay, let's be serious for a second. So, which test for advanced fibrosis? This is a well-known slide. Serum biomarker, well-validated, high applicability, high performance, better at ruling out than ruling in, low cost and wide availability for non-patented. Limitation, non-specific of the liver, and cost and availability for the patented test. Advantages of liver stiffness, genuine property of the liver, point of care if using FibroScan, can be performed in the outpatient clinic, high performance for cirrhosis, high evidence, thousands of patients, grading of steatosis. Limitations, lower applicability, failure between 3 and 7% if you use the XL probe, and of course you require a dedicated device. Now, regarding the serum marker, the message is simple. FIB4 and NAFLD fibrosis score, non-patented, are the most accurate for advanced fibrosis. This is a recent meta-analysis from China, thousands of patients, and you see the performance for advanced fibrosis. FIB4 and NAFLD outperform the other tests. Let's just concentrate on FIB4. Very simple test, age, AST, platelet, ALT. Available everywhere for free. Easy to calculate. You go online or you ask your lab and you get the result. 1.01, 95 negative predictive value. So you don't need to send your patient to the hepatologist. And I would like to propose this algorithm that we have written with Mirin Friedrich-Röst and Rohit Lumba that will appear next week on the website of Gastro. So when you're using non-invasive tests, the context of use and the setting is critical. So first line for GP and diabetologists, first, of course, you rule out the usual causes of liver disease, alcohol, viral hepatitis. Then you use a serum marker, and you can use either FIB4 or NAFLD fibrosis score. I know the diabetologists are quite fond of NFS, but I think for GP, FIB4 is much easier. If it's below 1.3, the risk is low. You don't need to refer your patient. Of course, you advise for lifestyle and exercise, and then further evaluation in 1 year. If it's above 1.3, very simple message, intermediate, high risk, you refer to the hepatologist. And then the hepatologist, of course, will use the measurement of liver stiffness with his favorite technique. Now, let's see the advantage and limitation of the different technique. If you look, the evidence, obviously, transient elastography has heavy evidence, several thousand of patients, as already mentioned. Quality criteria are well defined. Failure is actually a little bit lower with the IXL probe. Cost is lower than, obviously, NMRI and the other technique. And it's a point-of-care technique. And on top of that, you can also quantify steatosis. Now, the question is which cutoff? And I would recommend a dual cutoff strategy. And for instance, if you take 8 kilopascal, not 7.9, not 8.1, 8 kilopascal, plain number. And you look that the negative predictive value is very high, 94 to 100% for advanced fibrosis. So you can confidentially rule out advanced fibrosis in this population. If you're above 10, and I want to remind you that 10 is the cutoff for the so-called CACLD, then the positive predictive value as expected is not as good. But of course, it increases if you increase the liver stiffness. And this strategy has been used by a Canadian study that was presented at the last ASLD meeting using FIB4, large population of patients in primary health care with suspicion of NAFLD. And if you were below 1.3 with the FIB4, the probability of having transient elastography or liver stiffness measured by transient elastography above 8 was low, less than 15%. So back to algorithm. As an hepatologist, of course, I would recommend FibroScan because this is the most widely available and used technique. If you're below 8 kilopascal, the risk is low. You obtain lifestyle modification and exercise, and you consider to repeat, of course. If you're above 8, and then you can consider a liver biopsy, and this is, of course, much easier now with the ongoing available trial. In the case you have failure, and this I mentioned with the IXL probes, and this we can discuss, is between 3 and 7%, and then you can consider other techniques such as MRI, shear wave elastography, RFI, or patented test. These are my take-home message. So basically, they should be used on an integrated system. They are not mutually exclusive. And I can reassure you we are good friends with Pierre, and I'm still happy to work with him together. So NIT are good for triage in a large and selected population. Liver biopsy, of course, assessment in selected population in clinical trial. Thank you very much for your attention.
Thank you, Laurent.
Yep, we move on.
Move on.
So the next speaker.
No. Can you come to the...
Yeah. The next speaker is Professor Elisabetta Bugianesi, who also needs no introduction in the area of NASH. She has published extensively in this area, but she's going to specifically talk today about lifestyle changes and how effective lifestyle changes can be.
Thank you, Arun. Thank you also to Patrick Marcelin for this kind invitation, this beautiful meeting. Now, talking about lifestyle modification, there are three components to make it successful. The first is the low-calorie diet, the second is increased physical activity, and the third is behavioral therapy. Now, the usual dietary recommendation says to reduce intake by 500 to 1,000 kilocalories a day to lose half a kilogram to 1 kilogram per week. The diet should be balanced. Usually it is composed by 55% of carbohydrate, approximately 30% of fat and 15% of protein, but there should be low in cholesterol, in sodium, and high in the content of fibers. The second is physical exercise recommendation, that is moderate to vigorous exercise for at least 60 minutes on most days for at least 5 days per week. Walking is the preferred exercise, the famous target of the 10,000 to 12,000 steps per day that can be replaced by jogging 20 to 40 minutes a day, biking or swimming 45 to 60 minutes a day. Now, of course, exercise is not intended to make you lose weight because you can do that if you are an Olympic athlete, but it is intended to produce a calorie deficit of at least 400 kilocalories a day, favoring weight loss, maintaining muscle mass, and preventing weight recycling. In fact, higher physical activity enhances long-term weight control. You see that after the initial weight loss, weight regain is almost the standard. And if you have a standard behavioral therapy, then you regain more weight if you keep a high level of physical activity. The third component is the behavioral therapy because, of course, lifestyle change is a problem of the mind, not just of food. So the use of psychological techniques to modify maladaptive behaviors. In particular, the behavioral techniques should set a specific objective goal. Self-monitoring is very important, for example, keeping a food diet every day, and stimulus control. Basically, you should keep away all the bad food from you. Now, there are several ways of delivering lifestyle modification in group session, 10 to 12 patients, or individually with case managers, or with a multidisciplinary team composed by physician, dietitian, and or psychologist. This kind of approach works, and it has been demonstrated in several studies. I just mentioned a couple, the famous diabetes prevention program that followed more than 3,000 people overweight and with impaired glucose tolerance for 3 years initially, and then for 10 years. All these people were randomized to 3 groups: intensive lifestyle intervention, metformin daily, or control. At the initial follow-up of 3.2 years, the diabetes incidence was reduced by 58% in lifestyle intervention arm compared to 31% in metformin. And after 7 years of group-based quarterly lifestyle advice provided to all groups, they were also able to demonstrate that the onset of diabetes was reduced by 34% in the original lifestyle intervention and 80% in the original metformin arm, demonstrated that there is a long-term effect of the benefits of weight loss, even if you have some weight regain. This is basically what has been shown in the first 3 years. You lose some weight in the lifestyle, you gain some weight, but then the benefit is better than compared to metformin or placebo. And again, this is the incidence of diabetes with lifestyle, with metformin, and in the placebo arm. The same data were demonstrated by the Chinese counterpart, the Daking Diabetes Prevention Study, where more than 500 Chinese were followed for 20 years with a 94% recall, and the diabetes incidence was 93% versus 80% in the lifestyle intervention. And not just that, but after 23 years of follow-up, lifestyle intervention reduced all-cause and cardiovascular-related mortality. So this is one of the reasons why NAFLD, as any other metabolic condition, should be treated by lifestyle intervention. This is the main cornerstone of therapy. And it is aimed to a weight loss of 5 to 10% of initial body weight, as it is stated both in the European and the American guidelines for the management of NAFLD. This is based on some interventional studies. This is the first study with lifestyle intervention in patients with NASH. It was a small study because it comprised 10 controls and 18 patients in the lifestyle intervention. But after 1 year, they were able to see change in liver fat, reducing liver fat, reducing the NAS score. And when they plotted every single patient, including controls, over the change from initial body weight, they were able to demonstrate that if you lose more than 7% of your initial body weight, no matter how, if you are in the placebo or if you are in the lifestyle, then you are able to improve very much your liver histology. But the most important proof comes from this famous study from Cuba, where they enrolled 293 patients with biopsy-proven NASH that treated with lifestyle intervention, low-fat, hypocaloric diet, plus walking 200 minutes a week, plus questionnaire, plus group session, and they did a second liver biopsy after 1 year. The first endpoint was NASH resolution without worsening on fibrosis. And if you look at the impact of weight loss on liver histology, you see that it is changing and improving as much as your weight loss. So if you lose between 5 to 10% of your initial body weight, you have NASH resolution in 26% of cases, fibrosis improvement by at least one stage in 38% of cases. Then if you are able to lose 7 to 10%, you increase NASH resolution to 64% of cases and fibrosis improvement to 50%. And if you are really brave and you lose more than 10% of your initial body weight, then you have NASH resolution in 90% of patients and fibrosis improvement in 18%. So, getting better by lifestyle change, it is possible. What about nutrient composition? This is a famous study, approximately 10 years ago, where they randomized more than 800 overweight adults to receive different diets with the same caloric content, but with a different content of carbohydrate versus protein versus fat, starting from a carbohydrate composition of 65% and ending to 35%, and the reverse for protein and fat. And as you can see, there is no difference of the kind of diet that you use. So the diet that you should use is the one that the patient prefers, the one that the patient feels comfortable with. And they tried also in NAFLD NASH patients the effects of low carbohydrate versus low fat diet. They measure intrahepatic fat here. This is reduced carbohydrate, and visceral fat here. And if you look at intrahepatic fat, there is similar effect of reduced carbohydrate and reduced fat diet, but the reduced carbohydrate probably has more effect on visceral fat than the other. This is a very recent study in the German population with type 2 diabetes. They put them on isocaloric diets, high in animal or plant protein to reduce liver fat. They measure NMR spectroscopy after 6 weeks of treatment. The diet was composed by 40% of carbohydrate, 30% of fat, 30% of protein, and both diets achieved the same reduction of fat content in the liver. They also achieved similar reduction, particularly the animal plant diet, on visceral fat, and both of them were associated with a decrease in FGF21 plasma level. Now, I must say one thing, that probably the content of fat of this diet is a little lower compared to the general German diet, so there was some addictive effect of this low content of fat. Now, Arun was one of the first to compare the effect of different diets on liver fat. And here you see that the Mediterranean diet is the only one that was associated with a decrease in steatosis. And the Mediterranean diet is generally superior to low-fat diet in randomized controlled trials. Fat is approximately 40% of the calories, but it is a different kind of fat, rich in MUFA and omega-3 PUFA, so olive oil, nuts, and protein like fish, protein from legumes, a lot of fruits and vegetables. The carbohydrate content is reduced compared to the usual diet, 40%, and there is no soda drinks, no sweets, no red and processed meat. And this diet has been repeatedly demonstrated to be effective on clinical outcomes as well as metabolic profile. Now, this is a very recent study that has been published on Circulation last year, where they randomly assigned people with type 2 diabetes to a low-fat diet with or without physical activity. It's the red line, and the red dot line is the plus physical activity, or to a Mediterranean low-carb diet with or without physical activity. You see that the weight change, of course, was better in the Mediterranean diet, particularly with physical activity. They also measure by NMR spectroscopy all the sites of ectopic fat in the abdomen, in the liver, in the heart, in the pancreas, in the renal area, and in the muscle. And all these fat in the ectopic site was reduced by the Mediterranean diet that was superior to the low-fat diet. Talking about component, of course, fructose is a bad component, and although it remains unclear whether fructose per se causes NAFLD. But anyway, there is an association between sweetened beverage intake and fibrosis in NAFLD, particularly in adolescents and particularly in obese adolescents. Now, coffee. Coffee has been repeatedly demonstrated to favor protection from NAFLD and from NASH. This is the Rotterdam study where they measure liver stiffness in more than 2,000 subjects and stratified according to moderate or frequent coffee consumer, and the incidence of high stiffness higher than 8 was lower in the high coffee drinkers, and here also the odd ratio of having liver stiffness higher than 8 was lower in those who consume more than 3 cups a day compared to those who did not drink coffee, but only in the group with steatosis. It was unchanged in the group without steatosis. However, we should be quite careful to draw conclusion from this large study, particularly when they talk about meta-analysis, because if you take too much seriously this meta-analysis, you can say that eating 12 hazelnuts a day would prolong your life by 12 years, drinking 3 cups of coffee a day would achieve a gain of 12 years, and eating a single mandarin or orange a day would add 5 years of life. And today I missed my 12 years prolonged by coffee because I drank just one. Now, so in summary, the evidence of the effectiveness of this lifestyle change by clinical stage of NAFLD is summarized in this review. If you have a healthy liver, of course, you can have a Mediterranean diet and exercise to prevent fatty liver. If you have a fatty liver with or without fibrosis, then you should achieve a 7 to 10% weight reduction, and you should reduce your fructose and aim to a Mediterranean diet. Then when you have cirrhosis, this is a different area, and probably we don't have enough data to address this issue. So, weight reduction, in summary, is a well-proven clinical indicator of meaningful clinical benefits for the metabolic complication and for NASH. Also because NAFLD is a systemic disorder, and other important measure of success is diabetes prevention, reduced cardiovascular disease, improved mortality. And as all the natural history study demonstrated, the development of type 2 diabetes is a major determinant of fibrosis progression. The prevention of the development of type 2 diabetes is something to be actively pursued. And if you look at the last documents of the American Diabetes Association on the standards of medical care for lifestyle management, they talk about an individualized medical nutrition therapy program with a weight loss higher than 5%, no single ideal dietary distribution, so meal plans should be individualized, but the Mediterranean-style diet rich in monounsaturated and polyunsaturated fats probably is the one to be considered. And they also advise to avoid sugar-sweetened beverage to reduce the risk of cardiovascular disease and fatty liver. So what's the problem in all this talk? The problem is that if you look at the success rate, 70% of people who were enrolled in the Cuban study for lifestyle change did not achieve 5% of weight loss. Only 30% achieved more than 5%, and only 10% were the brave who were able to lose more than 10% of their initial body weight. This is because will is lasting approximately 2 weeks and is soluble in alcohol, as Mark Twain used to say. Now, the factors that are involved in weight loss and maintenance are several. For the dropout, the dropout is higher when you have higher weight loss expectancy. Your expectancy on the diet is too much. So you should address a more realistic goal. Then, what favor weight loss? An increase of dietary restraint, so stay away, don't buy unhealthy food. And what helps weight maintenance? A satisfaction with weight loss and self-efficacy, the intensity of physical activity, the percentage of weight loss during the first year, and also a regular contact with a counseling team. And if you look, and so training the mind, of course, it is very important. And if you look at the proportion of patients who reach the primary endpoint in the clinical trials published so far, this is in red, the active treatment arm, and in blue is the placebo arm. You see that the placebo success rate was approximately 18 to 20%. There is no spontaneous resolution of NASH. The problem is that a big component of this placebo effect was nutritional counseling, because these patients were very well motivated to change their lifestyle because their physician better explained the possible complication of their disease. And because their physician were following them more often, like every 3 months or 4 months, compared to the usual once a month that we have in clinical practice. So in summary, lifestyle change is an effective treatment modality for curing, controlling NAFLD and NASH, but it is difficult to achieve and maintain. It is important, the cognitive behavioral therapy with its 3 essential components, and we should use a multidisciplinary, holistic, individualized approach. And most of all, societal efforts should be done to change an obesogenic environment, because, of course, this is everything against something that push you every day to eat sweets, to eat more, and so on. And I thank you so much for your attention.
Thank you, Elisabetta. So now the last talk is by Arun Sanyal about new therapeutic in NASH.
So thank you, Laurence, and thank you, Patrick, for once again inviting me. And I will rapidly cover where we are with therapies for NASH. And as you can see on this picture, and as Pierre showed you, fatty liver disease covers a spectrum going from fatty liver all the way to NASH with cirrhosis. Now, as subspecialists, we are obviously concerned with liver-related outcomes. And liver-related outcomes, for the most part, occurs when you develop cirrhosis. So one of our key goals is to prevent the development of cirrhosis, or once cirrhosis develops, to actually prevent mortality. Now, this is a condition that is rooted in diet-induced obesity. While there are indeed people who are lean and have fatty liver disease, and there are all these other variants, for practical purposes, in the majority of instances, diet-induced increase in adipose tissue mass is the fundamental basis that leads to this clinical syndrome, which is also collinearly related with diabetes, cardiovascular disease, et cetera. So if that is true, then weight loss is a logical and initial approach in the management. And you already saw this slide, so I'm not going to belabor this data. But there is a popular paradigm of this 5% weight loss for steatosis, 7% for steatohepatitis, and 10% for fibrosis. So let's just take a critical look at this very quickly. So first of all, if you look at the people who did not resolve steatohepatitis, there were quite a few people who had more than 5% weight loss. So clearly it is more complex. Next, if you draw a line at the 10% weight loss, you will, if you look at the far right set of data of those whose fibrosis improved, you will notice 2/3 of these patients had less than 10% fibrosis, 10% weight loss. So clearly, this paradigm is incorrect, in my view. I think weight loss does not guarantee NASH resolution, and fibrosis improvement, yes, it does occur with increasing weight loss, but fibrosis improvement can occur even with less than 10% weight loss, as the data from this study actually shows. So that means we need drugs. And we have now developed a whole armamentarium of drugs and targets for the treatment because we understand the pathophysiology of NASH reasonably well, where the disease starts with metabolic overload of the liver. This excess metabolic substrate induces cell stress in the form of oxidative stress, mitochondrial injury, endoplasmic reticulum stress, which eventually kills the hepatocyte. Hepatocytes regenerate. In the process, you generate inflammatory signals. This inflammation over time is self-perpetuating and then leads to fibrogenic remodeling. So there are two approaches. You can either treat the front end of the disease and hope everything else shuts off, or you can go downstream and try to put a brake in the fibrogenic progression. So the two key concepts are that of disease activity and disease stage. So disease activity tells you how hard the disease is trying to drive this fibrogenic remodeling towards cirrhosis. And that is assessed by the presence of steatohepatitis and the various activity scores for routine clinical purposes. On the other hand, disease stage tells us how close you have moved to cirrhosis, how far have you progressed to cirrhosis. So it's a readout of proximity to cirrhosis, and since outcomes are linked to cirrhosis, the degree of proximity tells you also what your liver-related prognosis is. So this is the basis for how drugs are developed, where in the short term, for drugs acting on the front end of the disease, you want to see disease activity decrease with some effect at least on fibrosis or maybe not. And then in the long term, you want to show reduced progression to cirrhosis because that's what's linked to liver-related outcomes. So using those two regulatory bars of resolution of steatohepatitis without worsening of fibrosis and then fibrosis improvement. Let's see. So you already saw this. These are the data from the Pivens trial and from Kenkusi's trial with pioglitazone. And you can see what the effect size actually is. And then there are all the newer agents for which we have histological data. And you can see that the effect size, many of these are now in advanced trials, but you can see that the effect sizes are not dramatically bigger than some of the classical old studies with vitamin E and pioglitazone. So clearly, while we're making progress, we have multiple drugs that can reduce activity. We don't have anything that absolutely gets rid of disease activity in 90%, 95%, so there's more to be done. Similarly, when you look at fibrosis, we are making progress. In a number of studies, we are seeing that if you look at the green bars on the right, many of these drugs in these studies, the fibrosis proportion of people with one stage or greater fibrosis improvement was higher in the active drug, but I think only about 40% of these patients had some fibrosis improvement. So once again, I think there's a lot of room for improvement. So this is a field which is still increasing in speed, but I think there's still a long ways to go. Bariatrics does improve liver histology. So this is a review of 14,000 patients, controls, and 5,000 patients. And you can see that cardiovascular events, coronary events, cerebrovascular events are all numerically better and certainly statistically improved cardiovascular events. If you look at liver histology, 2/3 of the people lose their steatosis, 50% inflammation, 3/4 will lose ballooning. So you get dramatic effect on steatohepatitis. Fibrosis improves in about 40%. But interestingly, 12% of people had worsening fibrosis. So I think while bariatrics is clearly effective in some people, it's not the magic solution, and more work needs to be done. So it is a solution, it is not the solution. Now, to compound all of this, there's a very recent paper. It has not fully come out yet, but this is a retrospective analysis of people in a routine clinical care setting, in a real-world setting, who were given vitamin E for NASH and who already had stage 3 or stage 4 fibrosis. And what they show over here, over in a 10-year time frame in this retrospective analysis, is that vitamin E reduced mortality. Transplant-free survival is improved from 49% to 78% with vitamin E, and hepatic decompensation rate drops from 62% to 37%. Very dramatic, and this is the hardest evidence with real outcomes, not surrogate outcomes, published to date. So I think, once again, we need to, despite vitamin E is something that does not have a commercial sponsor, but I think it's a simple solution for a lot of patients. And I think given these data, we must revisit this in prospective studies to confirm whether these retrospective data are indeed correct or not. Because if they are, then I think this is a very dramatic finding in the liver disease, in the NASH space. So we have intense clinical trial activity. There are 4 phase 3 programs. And the pivotal trials, this is going to be a big year for NASH. We will have the first set of pivotal trials reading out. We'll have Regenerate trial with Intercept and obeticholic acid, Stellar 3 and 4 with selonsertib, and Resolve it with elafibranor that will read out this year. So, I think EASL AASLD will be a very busy time. So, what about the future? I think it's very important to understand that for most diseases, you have to treat the root cause. Treating hepatitis C with an antifibrotic will not solve the problem. You got to treat the hepatitis C. For hepatitis B, you got to treat the virus and reduce virus load, hopefully get rid of cccDNA. In NASH, you got to treat the metabolic overload. And so sustainable therapeutics have to be anchored on the metabolic basis of the disease. So what does cure look like? Cure defined as restoration of health, soundness, and normality, which means you have to go upstream to diet-induced obesity, because the excess cardiovascular, cancer mortality, along with liver mortality, all need to improve. You have to help the patient, not just the liver, because hopefully we're all doctors for the patient and not doctors for the organ. So while as hepatologists we are interested in the liver, liver-related mortality only accounts for 8% of all the deaths. in patients with fatty liver disease. The rest of it is extrahepatic. So we need to actually make progress there. So there's good news. We know GLP agonists across many different drugs now improve all-cause mortality and cardiovascular outcomes. As shown over here, the classic study is this LEADER trial. And now at least we have small trials showing that it improves NASH. And there's a phase 2 semaglutide trial that will read out this year, which will be very, very important, especially since semaglutide is now being developed as an oral agent. And we know that semaglutide given orally can act, well, I don't think this was oral, this was injectable. So semaglutide can produce substantial weight loss in up to 15%. And there are new combination GLP-1 GIP agonists shown on your right, which also produce substantial weight loss. So I think pharmacologic weight loss can actually be a reality. Similarly, SGLT2s have been shown to improve all-cause mortality and cardiac outcomes in diabetic patients. And we have early data now that it can reduce fat in the liver. So I think this is another class that I would keep an eye on. So what about the next frontier? It's combination therapeutics. So Gilead has already jumped into this in a big way. Here's the current data where as it stands, where you see the data for selonsertib in blue, acyl-CoA carboxylase, ACC fat synthesis inhibitor in orange, FXR in green, and the combinations. And these were presented earlier this year, last year at EASL, and this is the degree of fat reduction seen in these early phase studies. The only thing that worries me is that the monotherapies look better than the combination therapies in these data, but at least they're moving forwards. So I think as we, and this is the ATLAS trial that is currently ongoing, so very ambitious, a multi-arm study. So I think we were very interested to see how these pan out. But I think when you develop combination therapies, you have to be smart about it. It's easy to talk about combinations, but when you get down to it, you need to think about disease activity and disease stage. That allows you to divide this graph into 4 quadrants. Low activity, low fibrosis. Their liver outcomes are very low, so you don't need to expose them to drugs. Lifestyle. If you have mainly increased activity, but still no fibrosis, if you're going to use a drug, it has to be at the front end, metabolic drugs. But then if you end up with a lot of activity and a lot of fibrosis, the patient with stage 3 fibrosis who has a high activity, there you want to put a brake with the antifibrotic, and you then want to attack the metabolic. But then you also have to think, where is the patient going to end up? Are they going to end up in the lower left quadrant, in the lower right quadrant? What is your end game? What will you do if you reduced and brought them down to one of these quadrants? How do you maintain them? Are you going to give boosters? Are you going to have a low level of maintenance therapy? And then once again, once you get to fibrosis in the 4th quadrant, where you just have a scarred up liver, disease activity has gone down. If you treat it, again, it depends on where the patient ends up. So we really need to be more thoughtful about populations, relevant targets, relevant endpoints, booster strategies, figuring out whether you're going to do induction and maintenance therapy or how you're going to proceed forward, and the development path has to be modified accordingly. So I think this is a space where you're going to see a lot of activity in the next year or two. We've already moved to a point where we can actually identify molecular subclasses of NASH. So we presented this data at AASLD, where both for disease activity and for disease fibrosis, even though the histology looks the same, we can find unique clusters of patients who have unique sets of molecular drivers. And we think in the future, we will be able to match the molecular basis of the disease to the treatment. And that's how we get to the 90% response. The reason we can't push past the 40, 50% response histologically is because these patients have diverse sets of pathways that are driving their disease, and we're not hitting those targets. Finally, from a social point of view, a lot of work needs to be done. To reduce burden of disease, you got to understand disease biology, made a lot of progress there. We find druggable targets, preclinical studies, bring them into humans. We need to have a regulatory path for approval. We need access, so we need non-invasive markers that have to be qualified. But then we have to increase awareness in our colleagues, particularly in the diabetes community, primary care community, and ultimately change health policy, implementation science, and demonstrate effectiveness at the community level. And then we can say we can actually reduce the burden of disease. Thank you.
Thank you. We have 5 minutes for the discussion. So I remind you, you can send a question from your smartphone because I have only one question at this time. Maybe the first question for Elisabetta. The question from the audience is when are treated pioglitazone and vitamin, not D, E, in NAFLD patients? When to treat patients with pioglitazone or vitamin E? Do you treat your patient with vitamin E and
Yes, I do
pioglitazone?
treat my patient with vitamin E and pioglitazone. I do treat diabetic patients with pioglitazone, but also I advise for GLP-1 agonists. So I agree with the diabetologist, the kind of therapy that they can do. And usually liraglutide, for example, is more well accepted than pioglitazone because it is associated with a loss in body weight compared to pioglitazone. Even though pioglitazone is a very effective drug, there is this perception that has this side effect. Vitamin E, actually I do use vitamin E because it can be used on top of every effort to change the lifestyle because it's something more. I'm not definitely against drugs when they are effective, but they should be on top of an effort to change the lifestyle and to lose weight. It shouldn't be like the pill that solves everything because it doesn't.
Yeah, I would also add that 400 units of vitamin E also is effective. In fact, we did a very small pilot study before we did that, which led to the PIVENS trial, and where we used 400 units. And actually, it's remarkable that the histologic result was almost identical to the 800 unit result in the PIVENS. So, you know, if you're afraid of using 800 units for whatever reason, you could use 400 units, which has really never been demonstrated to be harmful.
Arun, do you recommend prostate monitoring for patients treated for a long time period with vitamin E?
So less now than I used to a few years ago, because there have been some recent meta-analysis summarizing a lot of literature, which have refuted the data from the SELECT trial, which suggested that in men over 60, there was a increase in the risk of prostate cancer. There are now a lot of studies, and actually the overall summary of the data no longer support that there is a major effect on prostate cancer.
Okay, one question for Pierre Bedossa from the audience. How do you differentiate alcoholic hepatitis and NASH in liver histology?
I think that theoretically it is said that we cannot, but practically there are some difference because, for example, when you have many mallory bodies and a lot of inflammation with polynuclears, and this is a good chance that it is alcohol. But the problem is often the etiology is mixed, and patients which have metabolic syndrome also have a drink. So theoretically we cannot, but practically we can have a sense for that, yes.
You think every pathologist or only expert?
I don't answer to this.
Okay, one other question about vitamin E. What's about vitamin E and diabetic patients?
Yeah, so we have actually looked at that in the Flint trial. In the placebo arm, there were, because we allowed people with vitamin E who had been on a stable dose for 6 months into the study. So when we analyzed the placebo arm, about a third of the patients were diabetic. So we actually found that those who were on vitamin E and diabetes actually had an even better response than the non-diabetic people. Very similar to what we saw with what Ken Kusi reported with pioglitazone, that the effect was better in the diabetic patients. So this is very common. If you're treating LDL cholesterol, if your LDL cholesterol is high, it's much easier to bring it down. If your hemoglobin A1C is high, it is much easier to bring it down. If it is almost near normal, it is very hard to move it, right? So I think we're seeing that those who have diabetes have just systemically more disease. So if you hit them, then you do see that response. I'm not sure there's something biologically significantly different there. What do you think?
Well, it is true that is an observation that comes commonly in all the clinical trial. Probably it's because the disease activity is higher, so the drug hits more the cause of this disease activity, but I do not have a definite explanation, but I have the same experience.
One question for Laurent Castera. Laurent, the gold standard to assess measurement of steatosis is MRI. What's about PDFF? What's about CAP? Because CAP is a point on care, it's easy to use, but what are the cutoff, and can we really measure the grade of steatosis with CAP, such as with MRI?
I think this is a very important point. So CAP is still under evaluation, but there are several papers, one recently from the group of Arun and another one that should appear soon. I think it can detect but not grade perfectly, because surprisingly, the more steatosis you have, the lower the OROC gets. I don't have any explanation. But for detection of steatosis, it works pretty well. Now the cutoffs are, I would say, above 250. So the scale goes from 100 to 400. It's likely that you have steatosis. But these data come mostly from patients without NAFLD, and maybe NAFLD slightly higher, probably around 300. But the nice thing about CAP, it's point of care. It's standardized. And as compared to ultrasound, it's widely available. It comes with a FibroScan, so you can kill two birds with a shot.
One important question for both of you. When to stop pharmacological treatment? Is it for life?
I will defer to Professor Elizabeth.
He is the real expert. Anyway, I give my opinion, but
No,
then the final opinion is him. The problem is that it is a chronic condition. So probably we are going to treat NAFLD in the same way we are treating type 2 diabetes. We are going to personalize the drugs, and we are going to see how the person is reacting to the drug itself. Now, there are different kinds of drugs. There are those who hit fibrogenesis, for example, and there, if you have the target to reduce fibrogenesis first and then to keep on maintenance, for example, by lifestyle or by some other metabolic drug, you can stop early the anti-fibrogenic drug, if there will be one. If there is something that controls metabolism, then probably it should be longer, until at least you attain, if possible, a lifestyle change which is comparable as effect to the drug. But anyway, it will be a chronic treatment.
Yeah, no, I agree with that. I have just some personal experience I can share with you, that we have some patients who were put on either pioglitaz, and we put them on a very rigorous exercise program, or those who are on vitamin E, and they actually managed to lose weight and so maintain their weight loss. So after 2 years, if they're initially we did some 2-year biopsies. Now we're just doing it non-invasively. If they look good, I've taken some of them off their medications, and we're following them to see what happens to their CAP and liver stiffness, and also their liver enzymes. It's too early to tell exactly how that will work, but I think the point you make is very good. If you're treating with a metabolic drug, like, then unless the patient's metabolic status has improved, you need to continue the therapy. But if you're talking about an anti-fibrotic drug, and right now we really don't have one that's clearly been shown to be effective, then once you reduce the fibrosis, you have to figure out, as I was pointing out, what you're going to do. Do you just do a remission induction like cancer, an induction and a maintenance, or you do intermittent boosters, and then you have to probably add something that deals with the root cause, the metabolic disease, at some point. So I think that's how it'll evolve.
I have one last question before closing the session. Is there any place for genetic polymorphism as a screening tool in NAFLD patients?
Well, for screening tools, the way at least I think about it, and others may disagree, I would do it if it helps me identify a subset of people where I would use a specific drug. You know, that if you have this, then you will not respond to this drug, but you will respond to this drug, because it will change what I do with the patient. And otherwise, if I don't get that kind of information, I'm just doing a test. I'm treating myself. I'm not treating the patient, you know? So frequently we love getting all these fancy tests, but unless it helps us alter the management, I'm not sure that it adds value.
Okay, so I would like to thank all the panel experts. I think we can, for the discussion and the presentation.